welcome you very warmly to our annual general meeting 2025 for Crohn's and Colitis UK. Thank you so much for coming. It's wonderful to have you here. First of all, just to introduce myself, I'm Jackie Crosati. I'm chair of the board at Crohn's and Colitis UK, and I'm leading our AGM today. So just a couple of housekeeping points before we begin. The first thing, very important, is using the Q&A function for questions for our speakers. You'll see it somewhere on your screen. We've given you the icon there. If you could press on Q&A and pose your question, and we will probably not be able to answer individual questions, all of them, but we'll clump them into themes and we'll make sure we cover all the points. So if you want to say anything that isn't a question to the speakers, then please use the chat function, and it won't be seen or answered by the speakers, just so that you know that. We're exclusively focused on Q&A for that. And we're also going to record the session, so I'm just letting you know that. Contents of the chat won't be part of that recording and won't be shared afterwards, so that remains anonymous. And finally, I just wanted to let you know that our governance does not require us to vote on our annual accounts and re-election, so we won't be doing that at the end of the meeting. Okay, I think that's the housekeeping done. This is our agenda, so just very briefly to guide you through it. We're really thrilled to have the esteemed Professor Christine Norton with us. As you can see her title there, Professor of Clinical Nursing Research at King's College. And she's the chief investigator on the IBD Boost project. This is an important piece of research, aims to develop and improve the well-being of people living with Crohn's and colitis as they experience fatigue, pain, and urgency. And she'll be sharing key information from this project. She has kindly agreed to answer some questions, so that's when there'll be an opportunity for Q&A. Then I'm going to talk you through some of Crohn's and Colitis UK's achievements for the past year and our activities, and then I'll hand over to Paul Richmond, who is chair of our Finance and Audit Committee, and he'll present to you our financial performance. You'll have another opportunity to ask questions at that point. And then I hand you back to our Chief Executive, Marianne Radcliffe, and she's going to talk you through the plans for our really dynamic and exciting 10-year strategic ambition before we bring the meeting to a close. So that's the plan for today. So first of all, it's my great pleasure to introduce Christine Norton, Professor of Clinical Nursing Research at King's, and she's going to share with us the update on the IBD Boost programme. Over to you, Christine. Thank you so much.
Thank you. Can I ask somebody to confirm that I am screen sharing?
You are, yes.
Oh, good. Thank you. Thank you. So I'm delighted to be with you this morning. And please let me know if these slides are not showing well on your screen. So I'm going to present to you the results and some questions and hopefully some answers from our IBD Boost programme. We have a major research programme on fatigue, pain and urgency and incontinence in IBD. And I want to talk to you about what we've found. So when we started this programme, what did we know? Well, we knew that pain, fatigue and bowel control are among the top concerns of people with IBD, and we knew lots of people, even in remission, had experience of fatigue, pain and urgency and incontinence. So we knew there was a lot of it about. What we didn't know was how to manage it. So we'd worked together over many years with Crohn's and Colitis UK and worked together with yourselves on several studies. We'd had a big lottery grant on IBD fatigue where we'd conducted interviews and developed a fatigue scale. We'd done interviews and a survey on incontinence in IBD, and you'd funded a PhD fellowship on IBD pain. So what do we know? Well, people with fatigue told us a lot about how fatigue felt. This was way beyond ordinary tiredness. This was a huge burden for people. These are quotes directly from people in our interviews describing it as a brain fog, like somebody pulling the plug out of your bath, like wading through porridge, never having any remit from this fatigue, feeling of being shot at. So it was way beyond ordinary tiredness. So we developed a fatigue scale, which is downloadable and that people can take to their appointments to score how bad their fatigue is. When Louise, who had the PhD fellowship that you funded, did her PhD, she talked to people about their pain. Some people able to keep going through their pain, but other people saying it's tense and then everything tenses up and it gets worse. Lots of people really scared about taking strong painkillers for their pain and slowing down massively. Trying to be the best mother you can is again a direct quotes from people, really impacting people's lives. And we also interviewed people with bowel incontinence, really worrying, really panicking, feeling disgusted, humiliated. One person telling us it ruined the person I was, I just don't bother going out. And a real don't ask, don't tell culture with this as well. Unpredictability being as bad as actual incontinence, just never knowing you're safe, never knowing if today's the day that you're going to be let down by your bowel, and having an accident in public was a real haunting feeling that you're going to be humiliated. So we conducted lots of previous research before Boost. This was one study we'd called FINS, the Fecal Incontinence Intervention Study, where we tested a booklet which we'd written for people with bowel incontinence and IBD, and compared that with having the booklet as well as 4 sessions with an IBD nurse over 3 months. This study, unfortunately, was a disaster. People didn't want to come to more appointments. They didn't want to come and see the nurse. They said, I've already had enough days off work, thank you very much. So we wanted 186 people. We only got 67, despite all sorts of attempts and trials. And those who did start, of the 67 who did start, only 21 completed. They didn't want visits. The nurses said, we don't have time to book people in for these visits. And most people actually didn't need the 4 visits. So they dropped out before the end of our study because they said, well, I just needed the booklet and a bit of help. 1 session was plenty, thank you. So we learned a lot from this, even though it was a bit of a disaster from our point of view. So we'd done a lot of previous research before we came to IBD Boost. So IBD Boost was a program grant from the National Institute for Health Research trying to improve fatigue, pain, and incontinence or urgency, and people told us they wanted to talk about urgency, not incontinence, in IBD. And we applied for this. We'd applied 3 times, in fact, and finally got it to start in 2017. The government gave us £2.4 million for this programme grant. It was meant to be 5 years, but COVID came in the middle, so it actually ended up being nearer 7 years by the time we'd finished. What did this program include? Well, lots of different things. It wasn't just one big study. What we call qualitative research was interviews with patients on what their priorities are, what they wanted, and with IBD nurses on what was their capacity and how could they support people on an intervention. So we did focus groups, we did interviews. We did a big survey on the symptoms, their associations, and how the symptoms clustered together. We developed an algorithm, a care pathway for IBD nurses to detect reversible causes or potentially reversible causes for symptoms, to treat them and then reassess. Then we co-designed with over 100 of your members an online self-management program. And then we did what we call a randomized controlled trial, and I'll explain this in a little bit, of an online self-management package, which we co-designed with IBD nurse support versus care as usual. And I'll go through each of those and tell you what we found in this research program. So when we interviewed people, it was very clear right from the beginning, they wanted holistic care. People told us see me as a person, not just my IBD, and not just am I flaring or not. And this is one quote from one of our participants. All they ever asked, this was in clinics, is how often I poo and am I bleeding? Nobody was asking about fatigue or pain or how are you? Or are you feeling low? Are you feeling anxious? Are you getting to the loo in time? All they wanted to know was poo. Now, that's obviously a gross generalization, but that was a general feeling. They weren't being treated as an individual or a person. People felt they were being treated as, am I flaring or not? And in the interviews, people described vicious cycles of symptoms, not just one symptom. We asked about pain, fatigue, and urgency, and people couldn't disentangle these when they talked to us. I suspect there's lots of other symptoms in the mix as well, particularly depression and anxiety for some people, but they couldn't disentangle this. Here's a quote from someone: each symptom reaction begets another one. It's a chain reaction for me. Can start with one, but a number of things can cause the chain reaction, but it's definitely a chain. I never get one symptom alone by itself. And this was a very common theme for people. The other thing that was very clear was that the cumulative impact of multiple symptoms, people not just coping with one symptom, but with many different symptoms, and relentless presence for some people. Every time I'm stressed, it messes my bowel. I have to poop 500 times a day. And obviously that makes me tired. It's a never-ending cycle. And multiple impacts, not just from the practicalities of symptoms, but impacts on the life. If I don't know where the toilet is, I can't socialize. I tried to go to the gym and having to rush to the loo all the time, just thought this isn't worth it. There's no way I can do this. So people described to us very clearly what the impacts were and also what they wanted from an intervention. People told us very clearly what they wanted. They didn't want more hospital appointments. They didn't want more tests, thank you very much. They certainly didn't want more colonoscopies. They'd had enough of those. They wanted to be able to try self-management at home at their own pace when they wanted to, but they felt they needed a bit of support with the self-management. So those were the interviews. We did lots of them. Then we did a survey. This was online, or you had a paper option if you wanted it. And I'm sure some of the people here today actually helped with our survey and filled in our survey. And what we were aiming to do was understand the relationship between symptoms of fatigue, pain, and incontinence in IBD. Not just have you got it, have you not got it, but are they related to each other? Because we suspected they were. We got nearly 8,500 responses. And the questions we asked were about the last 2 weeks. 30%, nearly a third, had had fatigue in the last 2 weeks. 21%, so 1 in 5, had had pain in the last 2 weeks. And a whopping 54%, so over half, had had an episode of incontinence, 1 or more, in the last 2 weeks. This is huge. 10.9%, so nearly over 1 in 10, had all 3 symptoms in the last 3 weeks. And we found they were related to each other. If you had one, you were more likely to have the others as well. And we asked people if they wanted help. Do you not want help? Do you maybe want help? Do you definitely want help for this symptom? And not just those who had the symptom, but overall of our respondents, over half wanted help for fatigue, 42% for pain, 53%, so over half for incontinence. 29%, nearly a third, wanted help for all 3 symptoms. And we concluded from this that there's a very heavy symptom burden, but we're not addressing this at the moment. We're not giving people the help that they want. And these aren't to scale, but the overlap between symptoms was very evident from our results. And so was the wanting help for symptoms. Again, not to scale, but people told us they wanted help, and they wanted help for more than one symptom in the majority. So that was the survey. In terms of Optimize, what we called our study, where we were looking at who had possibly missed physical causes for their symptoms. This was a nurse-led assessment, and we developed a consensus from IBD nurses and gastroenterologists on what the common causes for these symptoms were and what should be done, what actions should be taken. So in this study, patients completed a checklist and they sent a postal poo sample to our laboratory. The nurse reviewed this using our algorithm, using our care pathway. And it was fairly simple. There were a lot of details behind this, but we checked for red flags. Was there anything there that people ought to have dealt with urgently? Were there anything, that really should be dealt with as a medical, not emergency, but urgently? We then reviewed the checklist responses and the poo test results to see if disease might be active. And if it was, you treated that. And then we had steps for fatigue, for pain, for urgency. And if all of those were as good as they possibly can be, then people could be recruited into our trial of the online intervention. So this study was really impacted by COVID, sadly. We intended to have 20 hospitals involved. Hospitals couldn't participate during COVID. It was a complete disaster. We ended up with only 4 hospitals instead of 20. But nonetheless, we did what we could. We invited 500 people who answered the survey from these 4 hospitals. 200 consented. Most completed the checklist. Of those, very few had red flags, so that was reassuring. Most sent their poo test back to the laboratory, which was great. And of those who'd responded, 1/3, 35%, needed something doing. So over 1/3 had something which wasn't as good as it could be and that needed doing. And most people sent the follow-up at 3 months. So we found this was feasible, but it wasn't a big enough study to say definitively people got better. We interviewed Optimise nurses. They were very positive about it. They liked talking about these symptoms. They felt it helped patients. It built their confidence quickly. Did they think it was possible to implement this in your current NHS practice? Yes. They liked and thought patients appreciated someone going through this with them. They thought it was cost and time efficient. One nurse saying it's absolutely brilliant. I would put that down, wouldn't I? But they did. They were very, very positive, and they thought it was simple, straightforward, easy to follow. So we found from this study that it was feasible to do this. Not everyone wanted it, and that's fine. The nurses liked it, and the people living with IBD appeared glad to be asked about these symptoms and willing to fill in a checklist and return a stool sample. And interestingly, over 1/3 had something which could possibly be better managed. So we concluded there that we knew from the survey there's an unmet need. From this study, we found that people often hadn't been as optimally treated medically as they possibly could be for their symptoms. So then we went on to build our online intervention, and we built what we called a cognitive behavioral model, which is a psychological construct. We work with health psychologists to do this, looking at people's emotions, behaviors, and cognitions, the way they thought about their symptoms. We had lots of user involvement, and what we did with our 100 users was develop a 12-session online intervention with a therapist to support it. So you had an IBD nurse or a health psychologist supporting you. And we did a trial in patients who responded to our survey and rated the impact of their symptoms at least 5 out of 10 and said they wanted help. So we developed a nice interface. We hoped it was bright and cheerful and engaging for people. We had on your left there, people filled in an individualized vicious cycle for their own thoughts, cognitions, emotions, what they thought about things. And on your right there, you can see they also had a symptom tracker. So we tried to individualize it to the person using the intervention. We developed what we hoped were accessible explanations, diagrams, some cartoons, some videos, some audio content as well to engage people. And we had 12 sessions, some very general on IBD generally, some very specific on improving your sleep, improving your stress, some addressing directly the symptoms on the fatigue, the pain, the urgency, and what you could do to help yourself. Sessions were about half an hour to 45 minutes, and you could work through them at your own pace when you wanted to. So if you chose to do it, in the middle of the night or on your day off or whenever, you could do that. You didn't have to do it in a specific order. And people had a facilitator, usually a nurse, but sometimes a psychologist, because again, the NHS was really impacted by COVID. So a lot of the nurses said, we can't do this at the moment. And the nurse supported the patient through their journey, guiding their understanding. So after they built their own model online, the nurse gave them a 30-minute phone call, looking at this model and thinking, well, what could I change here? What could I modify? And then there was insight messaging throughout the program for people to support them. And you're meant to do this for 3 months and then another 3 months on your own after the facilitator support had finished. So then we did a randomized trial, which means we allocated people who were up for this by chance to either get the intervention or have a 1-year waiting list to get the intervention after a year. So they were a control group. We measured at baseline before they started at 6 and 12 months. And we chose with patients with IBD primary endpoints, which means what were we aiming to change? Because we'd got 3 symptoms, we chose quality of life as our primary endpoint, and we used a question called the IBDQ, which measures inflammatory bowel disease quality of life as our primary endpoint. And we also had a global rating of symptom relief from 0 to 10. Did you get better? 0 was no improvement at all. 10 was as good as it possibly could be. And we also measured lots of other things, including the pain, fatigue, and urgency, anxiety, depression, and costs. And we did a process evaluation to work out, did people actually do what we asked them to do and what they thought about the intervention. So this is where it went a bit pear-shaped, I'm afraid. At both 6 and 12 months after people had started, on our primary outcomes, the IBDQ, the quality of life questionnaire, and the global symptom relief, there was no difference between the intervention and control group at 6 months or at 12 months on these 2 primary outcome measures, the quality of life and the rating of symptom relief. Oh dear. That's just representing it graphically. The solid lines across are really showing there's no difference between the yellow blocks and the purple blocks. In fact, some of the purple blocks were a bit better. The control group were better than the intervention group. We measured lots of other things. There was no difference in pain or fatigue or control of IBD between the intervention and control group. However, a bit of silver lining here, those participating in the intervention did have lower incontinence score at the end and higher what we call general quality of life, generic quality of life, not IBD specific, but general quality of life than the control participants. So a little bit of a silver lining there. In terms of our process evaluation, we did lots of interviews with people who did the trial and with the facilitators. People really liked this intervention. They really felt it had benefited them, even though the scores weren't great. We found that the facilitators did exactly what we asked them to do, so that was good. But I think the big thing that we found from this process evaluation was that those who did 4 or more sessions, there were 12 sessions, did much better than those who did less than 4 sessions, which I guess sort of makes sense, doesn't it? That if you don't do it, it's not going to help you. So we really felt that it was, or we found that it was better if you did more sessions, and those who did lots of sessions got quite a bit better. So we were obviously disappointed in our results. We found it was safe. There were no major adverse events. The mean improvement in both the intervention and the control group was 4 out of 10. Is that worth having in a chronic symptom that nobody's doing anything about it? Maybe just thinking about the symptoms and filling in the questionnaire really helped. Maybe it was too ambitious to combine 3 symptoms. Did we ask people to do too much? Maybe we gave too little facilitation support. Previous psychological interventions have done more, so maybe we needed more facilitator support. So what did we learn? Well, we learned that these are common, troublesome, coexist, that common medical problems may underline symptoms. In about a third, people wanted to try online self-help, but probably need more support to engage with the online intervention. The other thing we really learned was don't do research in a pandemic, but what can you do? So what are we doing next? Well, we're going lots more analysis to try and work out exactly who benefited. Can we target this to those most likely to benefit? We're going to try more facilitation, more IBD nurse support to increase engagement. And we're applying for what they call a development grant to get the IBD boost intervention ready for NHS rollout and develop it into an app. During the programme, we've published more than 20 papers from the programme grant. Should we abandon the whole idea of our online intervention? I don't think so. I think we've got something here. We just need to make it work better than it did work in our trial during the pandemic. Lots of acknowledgements. This is our wonderful Boost team, and there were lots of other people involved as well. Lots of enthusiasm here. And if you'd like to help us with our next steps and help guide us as to what we should do with this next, please get in touch. Here's my email address. Jot it down, or the Crohn's and Colitis UK team can give you my email address. Do get in touch, because we do want to take this forward, and we're convinced that this will help some people some of the time if we can get it right. So thank you for listening. I'm very happy to take any questions via the Q&A function.
Thanks, Christine. Great presentation. And pain, urgency, fatigue, we know are some of the biggest concerns for people living with inflammatory bowel disease. So really important study. And we know they have such a huge impact on people's lives. It'd be great to get some questions from people on the call, but I'm just wondering your thoughts on really actionable steps potentially for healthcare professionals and what you're thinking at the moment.
I think what we've done, hopefully, through this programme is raise awareness that these are common, bothersome, people want something done. So they need asking about proactively. People, I think, assuming that if something could be done, I'd be asked about this, so I guess nothing can be done. Or healthcare professionals being quite negative, saying, oh, it's your IBD, or, oh, let's do another colonoscopy to see if you're in flare. No, thank you very much. You know, people don't want that. So I think being asked about it, being brave enough, and maybe taking our checklist to an appointment to say, look, I'm really bothered by this. This is really impacting my life. Please do something about it. So to be braver, but I think also to reorientate appointments. It's not all about flare. Flare is important. Obviously, you want to keep your IBD under control, and that's really important for your long-term health. But actually, that's not all living with IBD is about. And I think maybe reorientating appointments to pay more attention to these and other issues. You know, I mean, we've found in other research, there's all sorts of other things that bother people about their IBD, not just our 3 symptoms that just aren't being covered, you know, intimacy, sexuality, pregnancy, all sorts of other things, anxiety, depression, for some people, some of the time. And people aren't being given the opportunity to talk about these things.
No, absolutely. That's really helpful, Christine. And certainly when I'm meeting patients, that phrase that you use, see me as a person, and that need for holistic care definitely really resonated with me. We have a couple of questions in the Q&A. One is about joint pain being a big issue, and it'd be great to know how that was covered in the pain category in the study.
Yes, so we looked at different types of pain. Obviously, for a lot of people, it's belly pain. And that's a predominant thing, but don't assume it's only abdominal pain, that's the only sort of pain people have. So joint pain, particularly in the sort of arthritis, arthralgia some people get with IBD. And again, I think so many people not associating it with their IBD, just saying, oh, it's my age, I've got achy joints, and actually not reporting it because of that. You know, the same with fatigue. A lot of people assuming fatigue, well, it's just my age, or I'm working too hard, or whatever, and not reporting it as part of their IBD. So quite a lot of people in the interview said, oh, I didn't realize that was a symptom of IBD. So I think, you know, again, taking that holistic view and reporting what you've got, you know, don't just assume it's something separate. It might well be part of your IBD to have joint pain, to have fatigue, you know, or the urgency, assuming it's because I had 3 children, it might also be part of the IBD. So, you know, telling people what's bothering you.
Thanks, Christine. I've just another couple of questions just to group together. Pain and urgency, obviously, as you've already highlighted, having a huge impact on people's lives, being able to work, being able to be out and about, being able to travel. Any, again, actionable recommendations and steps about what studies we might see in the future and where this might go in terms of practical support for people to help and manage this?
Yes, so we're actively developing all sorts of other interventions as well. We're not only focusing on Boost. So we've just completed with your members again a really nice study of acupressure, home acupressure. We got lots of volunteers from your members. They wanted to try this. We tried it for depression, but we found as well as depression got better, the fatigue got better. So I think, you know, we are actively, we've been trying active commitment action and commitment therapy for pain. People are trying all sorts of different approaches for these things. There is a lot of hope, I think, for the future, but also we just don't understand fully how these occur. So I'm a nurse by background, I'm not a doctor, but there are a lot of our medical colleagues actively researching the mechanisms behind these symptoms as well. So there's a lot of background work going on, and that's absolutely crucial to working out what we can do about these things. So is there going to be a pill for fatigue? Not in the foreseeable future, but it might happen at some point in the future. You know, is there going to be a quick fix for any of this? I'm not sure, but my background as a continence nurse tells me that for urgency, same techniques as we use with anyone with incontinence, pelvic floor exercises, resisting the urge, maybe some antidiarrheal medication can really help some people. So often simple things, it doesn't, you know, it's not going to involve surgery. Usually it's going to involve some simple things you can try for yourself, change your diet a bit. It's not a quick fix, it's not an easy fix, but there are things you can do to help yourself.
Thanks, Christine. I'm conscious of time, so I think we'll probably have to leave it there. You very generously put your email address up and said that people can reach out to you, which is fantastic. Thank you for that.
Yes, and if any of the listeners have got other questions, do email me directly. I'll answer it as best I can. I can't give you clinical advice because I don't know your case, but I might be able to help with some of that. So please don't be shy, get in touch. Or if your team, Marianne, could send me the other Q&As, I can answer it and you can send some answers back. Very happy to do that. And, you know, thank you for the support of the charity. It's been absolutely pivotal in our research, recruiting people for our study, supporting us with research grants over the years. We're much more likely to get good grants in this area if we work together with yourselves. So thank you. And we hope that you'll work with us as a charity. We're going forward with this Boost 2, we'll call it. So thank you for your support. It's been really important.
Thank you so much, Christine. Really, really interesting, fascinating. And now turning to some of our key achievements of the year, I'm really delighted to share with you some of our activities and successes. It's been a really good year. So first of all, a reminder as to why we're here. This is one of our volunteers, Seema, and she's pictured here with her son, Zayan. And both of her sons have been diagnosed with Crohn's, and she told us that having a chronic lifelong condition has been hard for everyone in the family, especially when there are drugs that worked in the past but then no longer do. When she spoke to us, she spoke about the unpredictability of the disease. You know, 1 minute everyone could be fine and then the next minute in hospital. So I'd like to share some of her feedback. Crohn's and colitis play a big part in getting people together to talk, feel supported and be part of a community. You feel less isolated when people are aware of the conditions, and Crohn's and Colitis UK have played a huge part in that. You're doing something so positive to have that platform where you can talk about it, where you can shed those inhibitions, where you can leave those embarrassments behind. They have been fantastic supporting me and my family. So this support that we provide simply wouldn't be possible without our supporters like you. Thank you so much. Now, as you know, one of the ways in which we offer support to people is by providing reliable, up-to-date, evidence-based information. Whether we're trying to empower people to make informed decisions about their treatment or care, or supporting them to self-manage, information can help at every step of the journey. So in 2024, our website received 5.8 million views. That's an increase of more than 9% from the previous year. And we had around 25,000 users of our medicine tool and talking toolkit. That's a bit of a mouthful. And over 100,000 completions of our symptom checker. And we got some feedback about our support from Sue, who lives with Crohn's disease. So let me just tell you what Sue said. I can't tell you how many times since my diagnosis of Crohn's 18 months ago, I have returned to your site and studied the resources. No matter what I'm looking for, you hit just the right note. Science-backed, but patient-facing. It's absolutely brilliant. Your work really is like a lighthouse in foggy waters. Kind words from Sue. So in 2024, we also created 11 new support resources, including our LGBTQIA+ health with Crohn's or colitis. After we identified a gap in our resources for this audience, we began by reaching out to our volunteers who identified as LGBTQIA+ to work with us, and they helped us shape it and improve content at every stage of its development. So we're hugely grateful to them. Okay, so a vital part of our work is connecting people who are affected by Crohn's and colitis to each other. In 2024, we held 61 virtual social events, enabling over 650 people to come together with others who may be going through a similar situation. We also introduced a new event for people living with a stoma due to Crohn's or colitis, or for people who may be having stoma surgery. We also hosted events for parents, carers, friends, and family members. So the Crohn's and colitis community tell us they value having a supportive, safe space to discuss their concerns and coping strategies with people who really understand what they're going through. Now, a move on to update on our campaigning work. A key for success for us in 2024 was our continued campaign to cut the wait for diagnosis, care and treatment for people with Crohn's and colitis. You may remember at the last AGM that at that point we had collected 20,000 signatures of support for our open letter to the Secretary of State for Health and Care in England. Since then, we made a good deal of progress. So let me update you. The final letter had almost double that number of signatures. Thanks to our campaigning work, 35,000 people in total signed. And we also raised £14,000 in donations through the campaign. You can see here a picture of our Chief Exec, Marianne Radcliffe, on the day when she presented the open letter to the Secretary of State for Health and Social Care, Wes Streeting. We subsequently received a government response from the Parliamentary Under Secretary of State for Public Health and Prevention, Andrew Gwynn, which he outlined the government's plans and a commitment to improving IBD care. I now want to move on and share with you some of our successes in the devolved nations. So let's start with Northern Ireland. Our team met twice with the Deputy Chief Medical Officer, Dr. Lorda Gergen, not sure if I've pronounced that quite right, and Ryan Wilson, Director for Secondary Care. These meetings focused on the importance of early diagnosis and addressing IBD workforce challenges. We successfully secured commitments to further partnership working and to a full IBD workforce census. We helped shape Portadown's successful funding application for the lower GI pathway pilot that you heard about. Excitingly, the Department of Health has said it will use insights from the Portadown pilot to improve routes to diagnosis in the future. In Scotland, we met with Jenny Minto, Scottish Minister for Public Health and Women's Health. She supported our call for a published plan for specialist nursing, including IBD nurses, within the long-term conditions framework. The Minister responded positively to concerns about delays in diagnosis and limited access to fecal calprotectin testing in both primary and secondary care. And she was also open to public supporting our work via social media and potentially attending our cross-party group on IBD to speak about her support of us. And in Wales, we had a successful meeting with the Welsh Government and the CNO's office following our letter on the IBD UK Welsh report. We were joined by Iola Thomas, one of our programme nurses based in North Wales. We highlighted how IBD nurses are often a lifeline for people living with Crohn's and colitis, but the challenges to access people face with services under pressure. We agreed to work together to assess the size and sustainability of the IBD nursing workforce in Wales ahead of wider projects on the NHS workforce. Okay, so a vital part of our work is revealing to the world what living with Crohn's and colitis is really like. The theme for Awareness Week 2024 was Face the Facts. This provided an opportunity for our community to share experiences and raise awareness for both the conditions and the state of IBD services. During the week, we also launched the IBD UK report, shedding light on the state of IBD care in the UK. We highlighted the urgent need for decision makers to confront the key findings of the report and to take action. Over 2 million people saw our posts via our social media challenges. Our story on the IBD UK report appeared on ITV News, The Mirror on STV in Scotland, and other sites, resulting in 72.2 million audience reach, equivalent to an advertising spend of 1.2 million. Fantastically exciting for us. We achieved over 90,000 engagements on social media and saw over 630 people download our resources. We also hosted an evening reception in the House of Lords, sponsored by Baroness Young of Old Scone, at which we brought together 60 guests to call for improvements to IBD care. Now, let's take a look at the funds raised by our phenomenal supporters in 2024. It was yet another record-breaking year for us, with our supporters raising an incredible £8.4 million compared to £7.7 million the previous year. We just want to say an enormous thank you to all of you for your huge efforts, which included running, walking, hosting balls, coffee mornings, football matches, quizzes and golf days, to name just a few of the ways in which you raise funds for us. Thank you so much. Now, an exciting, groundbreaking piece of research. Last summer, researchers at the Francis Crick Institute, Imperial and UCL, led by Dr. James Lee, discovered a weak spot in DNA that is present in 95% of people with IBD. This groundbreaking research was funded by us, thanks to you, our supporters, and the results bring us closer to an understanding and addressing the causes of IBD. Excitingly, we'll be able to target this pathway using existing drugs. So it's an enormous step, this research, towards the possibility of a future without Crohn's and colitis. Our media team achieved fantastic coverage for the research, including BBC News, The Guardian and the Financial Times. We worked with our supporter, Lauren Golightly, who shared her story as part of the coverage, and total visits to website articles on this story just in the UK reached over 2 billion. Now, in 2024, we continued to invest in the healthcare workforce, funding advanced training for IBD nurses across the UK, and we currently have 37 nurses on the programme. This here in the picture is Gail Martin, an IBD nurse at Ulster Hospital. Now, she was refused funding from her NHS trust to obtain a qualification to enhance her skills because she worked part-time. Through our IBD nurses programme, we at Crohn's and Colitis UK were able to fund her MSc. Drawing on her advanced training, Gail has now created a clinical nurse-led IBD rapid access clinic, which has delivered faster access to treatment, helping over 500 patients a year. As Gail explains, before it took at least 3 months for patients to see a consultant. Now patients can be seen within 1 week. We remain committed to reaching and collaborating to everyone with Crohn's and colitis in our community. In 2024, we commissioned research to understand how we can better connect with those from the Black and Asian communities in the UK. The research looked at their values and priorities, how Crohn's and colitis impacts their lives, and how their identity plays a role. It looked into how communities like to connect and interact as service users and supporters. It assessed how these audiences perceive the charity, their level of awareness of us, and how well our services, fundraising, volunteering, and campaigning work meets their needs. And finally, the research looked at how and where we can best reach and engage with the Black and South Asian communities in the future. We look forward to receiving and acting on the results of this research in 2025, and we'll share this with you. In 2024, we also continued our work with our Equality, Diversity and Inclusion Communications Panel, a group of 15 people from diverse backgrounds who inform our work in communications and marketing. Our EDI panel continues to provide invaluable support to ensure our communications work is representative and inclusive of all communities. And we also want to thank our YAP panel. YAP stands for Young Adult Advisory Panel, which continues to provide strategic input regarding the needs of young adults with Crohn's and colitis. And finally, but importantly, I would like to finish with a reminder of all the different ways that you can get involved in our work. You can take part in research, raise funds, take part in campaigns, or volunteer in many ways. If you're on social media, please do follow us on Instagram, Facebook, TikTok, or LinkedIn and share our posts. For those of you who aren't already, please do consider becoming a member. You'll help fund our work, and you'll also receive a Connect magazine, a radar key, and a Can't Wait card. Thank you so much, everyone, for your support, and thank you for listening to that update. As I pass over to Paul.
Yeah, morning everyone, and I hope you can hear me. I'm here to talk through the 2024 financial performance for Crohn's and Colitis UK. So thank you for that, Jackie, and I think it's really important that we link all of the great work we're doing to our performance and our viability as an organisation as well. As you've heard, 2024 was another record-breaking year in terms of income generation for Crohn's and Colitis UK. And it's really important that what we do in the Finance and Audit Committee is we monitor and manage the financial health of the organisation. In total, as you see from this chart, we actually raised 8.4 million in 2024 compared to 7.7 million in 2023, with legacies performing particularly well in 2024. During the year, the charity made a planned deficit of £150,000. This compares to a 1.1 million deficit in the year before. This was split between our unrestricted funds at £400,000 in deficit and our restricted funds at £250,000 in deficit. In terms of expenditure, we planned a significant increase in expenditure. Some key programs were deferred and delayed. So there was a slight decrease in 2024 where we spent 8.7 million compared to the 9.1 million in 2023. The biggest decrease was in our work around early diagnosis at 0.2 million as opposed to the 1 million in the prior year. But in total, our reserves were fairly steady. So our reserves fell slightly from 3.8 million to 3.6 million. So the next thing we'll talk about is the actual versus the budget for the year. And I think this really helps show you how we performed versus where we finished versus expectations. We're very fortunate as an organisation. We have a diversified income with important contributions from several teams, including our events team, membership, community fundraising, individual giving, legacies, merchandise, trusts and corporates. Expenditure, as you can see from the chart, was less than budgeted, and it was also less than the 9.1 million in the previous year. And this is mainly driven by, we had a large activity plan called our cause-led campaign, but we didn't deliver the expenditure we'd planned, and that was because we were anxious to ensure we hit the right audience with the right messaging. The cost of generating funds, however, increased from 2.5 million in 2023 to 3 million. And then this was behind the resulting increasing income, as you'll see. And the research was also reduced, with spend going from 1 million to 0.75 million. So that hopefully gives you some summary of how we performed actual versus budget. But I think on the next slide, what we actually talk about is some really helpful analysis on how we spend the money and how we also achieve our income within Crohn's and colitis. We do have a very healthy reserves position, which is why you will see that there is a expenditure is more than income. This is a planned position that we've got due to the health of the organisation. In 2024, the main drivers of the 8.4 income were 1.8 million from various events, which was a very successful year for us. 1.6 million from our legacies as well. So you'll see that's a majority of the orange pie chart. We also had 1.1 million from membership subscriptions and donations, another 1.1 million from trust, and we also had just over 1 million from community fundraising as well. So as you can see, we've got a really broad range of income to support our organisation. In terms of expenditure, so how do we spend that money? So it was slightly less, as we said, than 2023, but you'll see there's a real sense of all the various activities we do to deliver outcomes to our members and to people with Crohn's and colitis. We spent 3 million, partly driving our income generation, so actually supporting our fundraising that we delivered in a year. 0.9 million on membership costs and benefits, 0.8 million on our communications, 0.7 million on research as well. And the key things here were just to flag some of the research activity we did in the year included medical research grants to Edinburgh, Exeter, Cambridge and King's College University. And we also awarded evidence and research grants to Hertfordshire, Newcastle and Canterbury as well. As you'd expect for the charity, our biggest individual expenditure is staff costs, which did grow from 3.5 to just over 4 million in 2024, which relates to us effectively growing both our expenditure and our income every year in order to meet our objectives. So that's a quick summary of our financial position, but I'm pleased to report that we are still in a very healthy position overall as an organisation, and it was a very successful year for us. Right, I'll now pass over to Marianne.
Marianne, shall we see if there are any questions?
Thanks, Paul. Thanks, Jackie. And it's just great to see that we are in such a healthy financial position. Great to see that, again, another record-breaking year for the charity. Fantastic. And it's just brilliant to have the continued support of everyone on the call and our supporters doing lots of different things for us, walking and running and baking and trusts and foundations and everyone that supports us, our corporates as well. So just great. And I'm sure we'll continue to go from strength to strength next year. There aren't any questions in the chat at the moment about Jackie or Paul. I mean, I wonder if Jackie or Paul, there is anything that you'd like to reflect on specifically in terms of the highlight for you last year. It's been a really great year. Our income is looking phenomenal. So, you know, it's such a great story that we've got to tell today. Is there any reflections that you'd like to share? There aren't any questions at the moment.
Well, from my point of view, I'm very proud of the charity. I think we should thank the staff as well as our supporters for working very hard. I think the one area we haven't mentioned perhaps is the NHS, and just thinking, and we've touched on it through our wonderful IBD nurses and waits for diagnosis, but I think to reassure our audience that we are thinking very hard about how we really make a difference for our beneficiaries, with the NHS going through a difficult time. And I'm going to hand over in a second. I'll just give Paul a moment to come back in if he'd like to, but I am going to hand over in a minute to Marianne to talk about our 10-year strategic ambition, because we are absolutely determined over the next 10 years that we're going to see significant improvements through our efforts with all of you to make a difference between people with Crohn's and colitis. The other thing I would say personally, and it's just a small thing to say, which is that I have been delighted to begin the development of the Young Adult Advisory Panel, and to really try and communicate well with those under the age of 30 who often, at the beginning of their diagnosis with the condition. That's been very important to me. So we shall see more of them, I think, as we develop. Paul, is there anything you'd like to say before I hand on to Marianne?
Yeah, I'll just also, I've seen a few questions come up in the Q&A as well, and I think there's a couple particularly around the raising funds point, and I think it is fair to say it is the largest single area on the expenditure for the year. But that does cover all types of activity there. I see both Ruby and Meryl have asked around that. And that is everything from the individual events that we're doing. And I know I've been involved in some of those events in the last year. I did the winter workouts. So there's all the individual events, but there's also working on legacy income, and also areas such as corporate and individual donation campaigns as well. So it is the single biggest driver of income into the organisation as well, and it's something we have to continue to invest in if we want to continue to grow and have additional funds and reserves to support our strategy. I can also see there's a question here from Claire as well, to me, about where I'd like to focus our resources in the next few years. And I think, and I'm sure Jackie would support me on this as well, I think we really want the organisation to continue to be ambitious and continue to grow. And I think it's really, if you think about how we can make a difference from what Jackie was talking about earlier, it's making sure that we are supporting the great work being done with some of our university and research support that we're doing. But the key thing is really making sure, as we heard about earlier, we're making a difference to people in terms of the way we support them through the website, through the helplines, through the membership as well, and also raising awareness. And the one thing I've really enjoyed in the last few years is actually having people I know coming back to me and saying, I've seen some of your campaigns. I've seen it in the cinema. I've seen it in through the NHS or in some other way. And actually, I think the thing we've done really well in the last few years is really build that profile and have a real national impact. And I think that's what we need to keep doing. And it's making sure we're continuing to grow the income to then make sure we've got the ability to really have this national influence.
Yeah, I would agree with that, Paul. I think the two words that get talked about an awful lot at the Board of Trustees, is impact and reach. And we're trying to be very rigorous in how we use our finances, our income, to make sure we absolutely get sort of maximum impact for them and reach out to you. So on that determined note, I'm going to hand over to Marianne to talk about the next 10 years. Thank you, Marianne.
Thanks, Jackie. So over the next 10 years, our strategy is focused on what matters most to people living with Crohn's and colitis. That's being understood, getting a fast and accurate direction, and accessing the right care and the right treatment, and living well. As Jackie has mentioned already, you will have seen in the news, I'm sure, the recent announcement by the government about the NHS 10-year plan that was launched just a few weeks ago. And this plan speaks of prevention, it speaks of the move to digital, and moving care closer to home. And while all that matters a lot, what matters to us more than anything, and what matters most, is that people with Crohn's and colitis are not left behind. We welcome the focus by the government and the NHS on prevention, but for conditions like inflammatory bowel disease, where we know that prevention is not yet fully understood, early diagnosis and access to the right treatment must be a priority. We support the idea of neighbourhood care, but we're also really clear for people with Crohn's and colitis, especially those on complex treatments, access to face-to-face specialist care is not optional, it's essential. And we'll call for this to be protected. We're encouraged by efforts to embed patient voice and lived experience into NHS reform, but this must now move from promise to practice. At Crohn's and Colitis UK, we are absolutely committed to making sure this plan works for people living with the conditions. We'll work with healthcare professionals across the whole of the UK to make sure your voice is heard. It's your stories, your frustrations, your ideas, your resilience that has shaped our 10-year strategic ambition, which I'm very delighted to give you a brief update on today. So as part of creating our new 10-year strategic ambition, we've taken the opportunity to revisit and redefine some of our core purpose statements to guide this new direction. And here they are, our need, vision and purpose statements. So our need, why is there a need for the organisation to exist? Well, Crohn's and colitis are lifelong, incurable diseases that are on the rise. We urgently need better treatment to find a cure. Right now, we need to increase understanding of the condition so that people are diagnosed quickly and live well. What's our vision for the world? Well, quite simply, our vision is a world without Crohn's and colitis. And finally, our new purpose captures both our unique role and our clarity of intent, focusing on diagnosis, treatment and care, and the whole of our community. We inform, we empower, and we unite our community so people with Crohn's and colitis can lead better lives. So our 10-year strategic ambition has 4 pillars, and here's a quick overview before I go into a little bit more detail on each of them. The first one is transforming understanding of Crohn's and colitis. Second is unite researchers, patients and healthcare professionals to set out the roadmap to a cure. The third is drive improvements in diagnosis, treatment and care. And the fourth is support people to live well. Pillar 1, transforming understanding of Crohn's and colitis. Crohn's and colitis are still too invisible. Too many people do not know how to spot the signs or know what to do. And the impact of these conditions, as we've heard today, are not recognised. And we want to change that. We want to raise public awareness on a national scale, making sure far more people can recognise the symptoms early and know what to do about it. So we'll focus on educating healthcare professionals, but especially GPs, so they have the tools, the knowledge they need to spot Crohn's and colitis accurately and know what action to take. But change will happen when people come together. So we want to build a movement, a powerful grassroots network of people across the UK passionate about raising awareness in their communities. They will be the energy behind a national push to make Crohn's and colitis visible. Alongside this, our campaigning will inspire action. Our work will drive practical change, making everyday life more accessible and inclusive for people living with the conditions. Pillar 2, unite researchers, patients and healthcare professionals to set out a roadmap to a cure. Research is the engine that drives progress, which one day might find a cure. And we want to involve our community every step of the way. For people living with these conditions today, research can also change lives right now. We will invest more in research that's shaped by people affected by and living with Crohn's and colitis, focusing on addressing their current priorities. We'll strengthen global partnerships, including those with other charities and research organisations, sharing knowledge, collaborating, moving faster together. We know finding a cure won't happen overnight, so we'll keep our community up to date, translating the latest research so people know what new discoveries mean for them today and how they can be part of the future. Pillar 3, drive improvements in diagnosis, treatment and care. Too many people face a long and stressful wait to receive a diagnosis and start the right treatment. And all the while, their disease is not being properly managed. This can have a serious impact on their physical health and emotional well-being. And it puts an avoidable strain on healthcare systems in the long term. Our focus will be on ensuring that people are diagnosed quickly and accurately and begin treatment without delay. We will support healthcare professionals and prioritise reaching and working with IBD nurses so they have the tools, the training, the confidence they need. We'll champion innovation in diagnostic tools, which can help speed up diagnosis, disease management, and improve patient experience. We'll advocate for these innovative solutions to be widely adopted, working with partners to help them become accessible to everyone who needs them. And we'll amplify the voices of people with Crohn's and colitis, ensuring their experience informs decision-making in healthcare systems so patients receive better care. By involving patients, we'll work to influence governments and healthcare systems across the whole of the UK and call for change in national policy. And finally, Pillar 4, supporting people with Crohn's and colitis to live well. Most of the time, living with Crohn's and colitis isn't about being in hospital. It's about managing symptoms day in, day out, balancing work, education, family life, relationships, going out. Self-management is a huge part of life for people living with these conditions, which are fluctuating, lifelong, and unpredictable. That's why the right information, advice, and support available when it's really needed is absolutely vital. We'll provide trusted guidance on the issues that matter the most to everyone affected by and living with Crohn's and colitis. From managing symptoms to understanding treatment options, to dealing with the wider impact on daily life, areas like fatigue, food and diet, and emotional well-being. Not everyone has the same access to support, and too many people still struggle to find the help they need. And some communities face additional barriers. We're committed to breaking down those barriers. This means making our information and services truly accessible to all, not just to the people who already know where to look and how to find us. We know that connection makes a real difference. We'll bring people together, helping them to share experiences, build strong, supportive relationships, and feel less alone. A key way in which we'll deliver our 4 pillars is working to build strong foundations. This is our enabler for long-term growth. We want to grow sustainably and meet our ambition with confidence and purpose. And to do this, we'll invest in the systems, the people, the culture, and the resources that we need to grow. That will mean strengthening our infrastructure, supporting our people, improving how we use technology, and making sure we're resilient. Digital is integral to this and a key driver across the whole of this strategy. Whether it's how we connect people or the services we provide, or how we use insight to make decisions, or how we collaborate internally, digital innovation will be a golden thread throughout. It's about setting ourselves up for success so we have the confidence to deliver the biggest and greatest impact, reach more people, and stay true to our values. But for a moment, as I wrap up, I'd like to take us back to why we're here today and why we're creating this 10-year strategic ambition. It's all to support people like Lindsay, and I had the pleasure of meeting Lindsay recently at a patient information day. After I met Lindsay, we published her story across our social media channels, but I just wanted to flag and let you know, before I start talking about Lindsay's experience, that it does contain some harrowing details and information. Lindsay has ulcerative colitis. When she was just 9 years old, childhood bullies stamped on her and damaged her stoma, breaking her jaw and cracking her ribs. She was left in intensive care. She went on to become the first child in the UK to undergo J-pouch surgery, a pioneering procedure that gave her 20 years without a stoma. Lindsay, now 41, provides coaching for others living with Crohn's and colitis with the support of her husband and friends. When I met Lindsay, she was training to become the first person with a stoma to compete in the Endurance Fitness Challenge Spartan Deca Fit Europe, which takes place this September. Her story is a difficult one to hear, but it really does inspire all of us every day to make sure that the voices of people living with Crohn's and colitis are at the heart of everything we do. And it's the support that we receive from people like Lindsay and all of you that makes all the difference. So an enormous thank you for however you've supported us in the last year. Thank you for being a member. Thank you for signing petitions. Thank you for running, walking, volunteering, sharing our social media posts, and for everything else that you do. We simply could not achieve everything that we do without you. Thank you for supporting Crohn's and Colitis UK. So lastly, please do get in touch with us if you have any questions or follow-up from today's session. Here are all the different ways that you can get in touch and contact us. And thank you so much for being with us today.
Thank you, Marianne. So that brings our session today to a close. I'd just like to say thank you to all our speakers, particularly Christine Norton. Thank you so much for joining us. And just to all of you in the audience, just like to thank you once again for coming, for being our supporters, working with us, joining us. We really value you and very much look forward to seeing you all again next year and in between. Thank you so much, everyone.